Welcome to the Cardio Ohio podcast, a production of the Ohio chapter of the American College of Cardiology. This is Kenny Graywall in Columbus, Ohio.
This is Ben Allencherry, Cardiovascular Imaging Fellow from Cleveland, Ohio. More information on the podcast, including past episodes, is available at ohioacc.org.
And now for today's episode. So welcome back to the Cardio Ohio podcast. And we would like to welcome to our show, Dr. Santosh Menon from Cincinnati. He's a clinical cardiologist, a heart failure specialist as well at Christ Hospital, but he also is the medical director for the Cardiovascular Clinic for South Asians, which we're going to hear much more about. Santosh, welcome to the show.
Hey, thank you, Kenny. Thank you, Ben and Gwen, for having me. I'm really honored.
Yeah, we appreciate you as well joining us. Of course, just 2 weeks ago, you gave an excellent talk at our statewide Ohio ACC meeting with an overview of heart disease in South Asians. So we kind of wanted to build off your presentation, maybe reinforce some of the key points and also get into more practical advice about how we can manage some of our patients, the role of screening as well. But we thought we'd start by just asking you how this became an area of interest for you. In other words, what was your path from deciding to go into cardiology to ultimately having this position to start a clinic like this?
Yes, thank you so much. I always loved cardiology. I mean, it's so data-driven. All the studies have done it. Everything's guideline-driven. So I had a passion for cardiology from med school, doing residency. And then within cardiology, I really enjoyed doing heart failure, transplant, LVAD. And I did that for a few years. I evolved to do more general cardiology, heart failure, and of course, preventive cardiology. My interest with South Asians, really, I am ashamed to say, or maybe I should be proud to say, that I read about it in the New York Times with the article about the Masala study from the front page of it. And that got me fascinated. And then when you talk to other people, everybody has a family member, friend, or someone. As I made representation, my wife's cousin had an MI at a very early age, and that really tweaked my interest. And I thought, we look different. We have very little smoking, very few risk factors. We have this horrendous cardiovascular risk. And what is the basis of that? What are the studies? And what I found was that there really is not much study. Initially, most studies for Asians lumped everybody together, including South Asians, Chinese, Japanese, and the data was skewed because we were thought to have a low risk for cardiovascular disease. It's only recently that people started separating the data out, especially in England. They found that, yes, South Asians are a very high risk. And Masala study, which I thought was a great acronym, was really the icing on the cake to increase awareness, especially me, and to get more interested in this.
Yeah, and we're going to get into details about the Masala study, which I think has definitely expanded our knowledge. So, I've been practicing 25 years now. It's been 30 years since I started as a fellow. I remember in the late 1990s, some of those early articles that were first pointing out the risk in South Asians. I know a lot came from the United Kingdom in those days, dealing with South Asian immigrants. So in the last 20 years, have subsequent studies kind of confirmed that there is both a higher prevalence and incidence in South Asians, and also confirmed that perhaps the onset of disease is at a younger age as well?
Yes, apart from the Masala study, there's been several studies, really demographic studies, looking at South Asians as a separate population. And what they find is that it happens 10 years sooner than white counterparts. And also the risk of dying is 4 times greater when compared to case-controlled Americans. There was the MESA study, but that also, again, lumped together Chinese and Hispanics and South Asians. And again, you found that when you break down the MESA study, that there was a high risk among South Asians for developing coronary calcium, which, as you know, is a precursor to having a myocardial infarction.
And is it true, do you think studies have confirmed that the risk is high both in native South Asians in their home countries as well as those that have emigrated to Western countries?
Absolutely. As you know, diabetes mellitus, especially type 2 diabetes mellitus or insulin resistance, is at almost epidemic proportions in the South Asian countries. A lot of it is due to diet, lack of exercise, and probably a genetic component. And that does not change when you migrate to the United States or Canada or England, it follows you. So just moving to a country where, let's just say that maybe medical care is more advanced, you have more access, it does not change your risk. We carry that with us.
Yeah, that's perfect, Dr. Menon. And for our listeners, this Masala study we talked about, this is the mediators of atherosclerosis in South Asians living in America. It's by Dr. Kanaya from UCSF in collaboration with docs from Northwestern. And it kind of focused on South Asians living in America, trying to detail almost in a descriptive fashion what is the rates of coronary disease, but also what are some of the contributors. And that's kind of where I wanted to plug you in here. You have this clinic in Cincinnati where you're seeing the patients. And in the study, from some of the papers from the Masala study, they talk about, the BMI cut point for South Asians for obesity is around 27.5, lower than any of the other races. Do you see this where you have kind of coronary disease that's out of proportion to the BMI, meaning people are what we call skinny fat?
Yes, the BMIs have to be dropped for South Asians because we don't fit the criteria that is for obesity. And we tend to hide our obesity, what we call truncal obesity or obesity, which is much more arthrogenic. And that is not picked up in a BMI. For instance, in my South Asian clinics, I use waist to hip ratio, which we think is much more accurate to see which patients are obese.
Beyond the obesity differences and body composition differences, people have brought up coronary size, coronary diameter. Has that been something you've seen in either the literature or in your practice that has contributed?
What I see a lot and what the studies support is that we get extensive atherosclerosis. So it's not the typical proximal LAD 90%, which can easily be stented. It tends to be long, diffuse, ratty, something what diabetics would get. But a lot of these patients are not diabetics. They're not by criteria. They may be insulin resistant, but they're not diabetics. They tend to be diffuse. They tend to be more distal, the lesions. And they tend to be dense lipid plaques and very high calcium scores, suggesting a lot of plaque burden at a very young age and at a very low BMI.
Yeah, that's an interesting point. And I'll transition to Kenny here on a topic he is near and dear to his heart because he's an avid golfer and still really active. In the Masala study, I think South Asians were like very significantly lower in terms of how much exercise they did each day. Is that something you're seeing as well? And how have you kind of used that in a management tool to encourage South Asian patients to kind of get out there and get moving?
It's a great point. I mean, the study shows, the Masala sub-study, that compared to white counterparts, we tend to walk about 4,000, 5,000 steps less using a pedometer. And I think that is a tremendous risk factor. There are many factors. One, as you know, as South Asians, it is ingrained in us to study, work hard, and not spend too much time exercising or doing sports and stuff like that. But also there are social barriers, especially in females. Studies have shown that females of South Asian descent, especially those that have only been in this country for a few years, have barriers, not just basically, getting to a gym, but going to a gym, working out in front of other people, walking in the street and stuff like that, moving. It is difficult for them because of these barriers. And a lot of females who also have a very high risk of heart disease among South Asians, they're the key players in the families. I mean, they do all the cooking, they take care of the kids. They have no time to look after themselves. I mean, I see it a lot in my South Asian patients. Sometimes the husband and the wife come together to see me. When the wife is my patient, the husband does all the talking for them and explaining the situation. So there are many reasons as to why South Asians are just not that active. And one of them being it's ingrained in us. Number two is that I believe that there's a lot of social barriers to exercise.
Yeah, Santosh, I think those are great points. I will say, as a South Indian and a 33-year-old who still plays basketball once a week, I'm waiting for my call up from the Cavs to be their 13th man. So don't wreck my dreams.
Those that were born and brought up here really have taken this and are really taking care of themselves, at least exercising a lot more. But it's the other generation, our parents' generations who came here, worked hard to get here. And studies have shown the more senior you become in your company or in your institution, or you become a professor, the more sedentary it becomes. Also, stress is a very important. Mental stress is a huge factor in South Asia. If you talk to all South Asians, even the young ones who work in IT, they're stressed to the max. And that also is very pro-arthrogenic.
Yeah, I'm glad you brought that up, Santosh. I do think that's a commonality I see in my patients as well. One point about exercise that's very interesting because that you do see a lot of young, extremely athletic patients who still develop atherosclerotic disease. And so that exercise, even though it can be protective, it certainly doesn't prevent you from having atherosclerotic disease because sometimes people are actually becoming more active because of their family history or because they already had other risk factors. Do you see that as well?
Absolutely. And that is one thing I recommend is at least you can't negate maybe your genetics, but you can sure negate other risk factors such as sedentary lifestyle. One thing I do tell them is whatever it takes, get down to your ideal body weight, get rid of the fat. And I think your insulin intolerance and your type 2 diabetes will get better automatically. It'll help your stress. There absolutely is no downside, I think, in South Asia or any population, but especially South Asians, to exercising. Our muscle mass is less. So we tend to hold on to the weight in our abdomen and our arms tend to be thin. And as you know, you need muscle to absorb glucose and to store it. And less muscle mass means less glucose storage. So I tell my patients, aerobic is great, but you also have to use weights and would do resistance training. That's very important.
Yeah, absolutely. Before we move on to talk a little bit more about management and screening, you mentioned early on about the diabetes, about the explosion and the incidence, but is there anything we can learn about the presentation of glucose intolerance in South Asians that may be different than general populations? Is there anything different in terms of a screening regimen, in terms of like what cut points you might use to consider someone pre-diabetic, for example?
From what I've seen, almost all of my South Asians, even some of them that are runners, they tend to be glucose intolerant. That means that their fasting glucoses tend to be not in the diabetes range, but they are moderately elevated, suggesting insulin resistance. Sometimes some people recommend, some of the studies have recommended you an insulin level. I've done that in a couple of young patients, but really in my policy now with South Asians, especially ones who are really motivated, get their numbers down, almost everything to normal. So an A1C less than 5.7, 5.5, LDL less than 60, 75. Those numbers blood pressures that have to be perfect. As you know, in the Masala study, they found that we had a higher incidence of high blood pressure and increased fasting glucoses and type 2 diabetes and elevated calcium levels. So really, you got to get these numbers down to normal in most patients.
Yeah, well, I think that's a great way to transition a little more into screening and targets. So let's just take a theoretical patient, a 35 or 40-year-old South Asian professional. Maybe they have family history of coronary disease or other cardiac events and relatives. They don't have any history themselves, but they haven't really been the most thorough about tracking their primary prevention measures. And they're coming in to see you for risk assessment. So, we're all general cardiologists and we understand, the bread and butter things we're going to recommend to every patient. But what are the things you would tell them to focus on if they're coming to see you for the first time, they're asymptomatic, in terms of where they should be, what targets they should be shooting for things like lipids, blood pressure, stress reduction, and so forth?
I tend to look at their risk. I try to stratify them, look at, of course, like you said, the family history, their waist to hip ratio, their blood pressure, are they obese, and really try to target to them, really getting their blood pressure down to normal, getting the glucose is completely back to normal, and the lipids. Now, at the age of 35 and 40, unless they have tremendous risk of coronary disease, that means that they have a little bit elevated glucose, the HDL, which is commonly low in South Asians, and the triglycerides are up, and they have a family history. I'll do a calcium score early in these people. You'll see even specks of calcium is a risk factor, as you know, for coronary. And I've seen it a lot in my patients at a very early age, rampant, heavy coronary calcifications. And the Masala study did show that the coronary calcium scores tends to be higher compared to a white counterpart. It was a more dense calcification of these plaques at a much early age. So sometimes South Asians need some convincing that, yes, you need to take a statin, you need to take aspirin, you need to exercise, watch your diet, and so on. And a calcium score is a great way, I think, of convincing them that, yes, it's a wake-up call, that you need to get something done and start acting on it now.
So even below age 40, you don't have any qualms about recommending a calcium score if the risk profile would indicate that it can help your decision making?
Below 40, I may hesitate, but like I said, those that I think are just, very type 2 diabetic or appear to be insulin resistant or their metabolic syndrome or they have a family history, I'll get that as a baseline and I'll follow that carefully, understanding that they could have soft plaque that could be missed. I don't do stress tests in these people unless they have symptoms. I don't do coronary CTAs unless I'm really, really concerned that they have an angina. Now, some people come with a coronary calcium score that they had done through their physician or through a health fair or whatever, or bring carotid studies, carotid Doppler vascular screening, and that'll show some plaque. But about below 40, I really have to have more evidence before I do it.
Yeah, that's totally understandable, Santosh. And just piggybacking off that, so say, just like Candy had said, in that young patient who comes in, has risk factors, has all the primary prevention indications, you start them on statin therapy, control their blood pressure, monitor if there's diabetes, you treat. How aggressive are you? Because, these are young patients. How aggressive are you in jumping to a lipid lowering management? How often are you using PCSK9, Zetia, et cetera, in these young patients?
As you know, South Asians tend to be intolerant of statins for the most part. There's a chunk of South Asians that have a gene that reduces their tolerance of statins. So you can't really go in high doses. I don't have a lot of patients on, let's say, 80 of Lipitor, but I tend to go to Crestor first. And if you look at the guidelines, they do recommend rosuvastatin for these patients. And I think that helps get their HDL up. And I will target, if they have some coronary calcium, I'll go to below 70, 75, and then maybe even follow the European guidelines down to 55. And the one thing about South Asia, which there's no data to support this, if they have moderate calcium, I will repeat the calcium score in about 2 to 3 years. I won't wait the 5 years that it's recommended in the guideline. And I will add Zetia. Zetia is very well tolerated in these patients because their max dose of rosuvastatin, they've lost some weight, but the HDL is low, the LDL is still in the 90s. I'll add Zetia, and I've had good results with that. I've only have a couple of patients who already have for secondary prevention, PCSK9 inhibitor, and they seem to tolerate that well. Of course, I will check vitamin D levels of these and use CoQ10 with them because our CoQ10 levels tend to be low in South Asians.
Yeah, that's an interesting point, especially here in Cleveland. I think everyone, regardless of your ethnicity or anything, your vitamin D levels are quite low. So that's often something we target when we're starting statins.
Yeah.
Looking at it from the fellow perspective, I know there are a lot of fellows in training who are listening, and it's quite a unique path you took, doing heart failure and then starting a South Asian clinic in a major city. Can you just share a little bit? I know you talked a little about the motivation, but just how it's been starting like a very specialized clinic where, like in Cleveland, we don't have this clinic, just how it's been, how the growing pains and how you've recruited people and how follow-up has been to get patients to buy in.
Yeah. I mean, it's been fantastic. I mean, helping people, especially our community. I spend a lot of time on educating the masses as well as my patients. And I try to see them through, they need some kind of coronary angiography or something. I, help them. But what you'll see is that South Asians like seeing doctors who look like them. So most of my patients, if they're South Asian, their primary care tends to be South Asian. And, for the most part, they tend to be very compliant. They've not heard all the stuff that I've told them about. I spend a lot of time on diet and how to change your diet, how to exercise within your constraints, how to deal with stress and social isolation, how to deal with depression and things like that. And actually, I have a South Asian physician who's a psychiatrist, a young girl, and her dad died of a sudden cardiac death, which was the resident of Christ, who helps me with some of my South Asian patients. You have to approach it from their side. You can't just tell them, here, take this pill, come back and see me in a year. They just won't do it. So I discuss what is your plan? What is the barriers? What is your barriers to a really good diet? And I'm not a dietitian, but I do recommend to them, for the most part, think about something like a Mediterranean type of diet. And once in a while, eating South Asian food is fine because that is a attachment to our culture, but you can't eat it all the time. Because I suspect that is a common factor as to why we develop all this arthrogenicity. But it's been great. I mean, they're wonderful patients to take care of. Some can be frustrating, of course, because a lot of them have medical people in their families who want to give an opinion about their dad's or mom's care, or they want me to get them on the phone and stuff. But they're grateful. They follow up, they show up, and they try to do what they can. But I try to tailor it to each one of them. And I think they feel more comfortable talking to someone who looks like them, talks like them, understands where they're coming from. So it's been great. It's not, it's not like it's not like bursting from the seams, but I'm getting there. I always recommend to my patients that if you have a very good primary care physician, very good cardiologist, and you're happy, they're taking good care, see them. I can help you out once. I can give you a recommendation. You can take it back to them that you should be on these kind of medications and with these kind of targets. But I think I spend a lot of time educating and doing also free care for, as you know, there's a big population of undocumented South Asians in the Midwest who work, but they're not documented, so they don't have insurance and things like that. So we help them out a lot of educating, checking blood pressures, EKGs, and doing free echoes for these refugee population and undocumented people. So, but as you know, South Asians are, they're different cultures and different ways of approaching them. But so far so good. It's been really great. It's been very satisfying.
Yeah, I think it's inspiring, regardless of whatever discipline you're interested in. I know you run a busy heart failure practice at a major hospital, but even to have the time and the dedication to promote your time in this area is it's awesome to see, and it's inspiring for us fellows.
Santosh, that's a great story to hear. I'm glad you brought up the diet because we didn't have a chance to ask you about that earlier in our discussion. But obviously, a lot of South Asians are vegetarian. But would you agree that that doesn't necessarily mean that they're eating a healthy diet? And as a follow-up to that, what advice do you give some of the first generation or even the immigrants who are still holding on to their South Asian type diet? What advice can we give them on changes they can make, to make it a little more healthier?
Absolutely. Yeah. I think the diet is our biggest part. I mean, we eat high carb, low fiber diets where the blood sugar goes up immediately in our bodies. Our insulin levels go up even higher to overcome this glycemia. And that gets stored as fat in our bellies, and that can be hidden but it is a link to our culture. So what I tell my patients is that, and I ask them about diet very much in detail, and they like talking about their diet, because you understand the words that they use, chana, roti and stuff like that, which a Western doctor may not understand. And what I tell them is that you don't have a choice anymore, especially those that have a calcium score, they've had a heart attack, or they've had bypass surgery. Unfortunately, those days are long gone. When our ancestors ate this kind of food, first of all, they don't eat only one meal a day, and they would walk everywhere. Studies have shown that those South Asians that live in the rural area have a 50% reduced BMI and a waist to hip ratio and a lower risk for cardiovascular disease. We're eating the same foods, but we're not as active. So you got to change your diet. You don't have a choice. And I just keep it simple. It's, again, because I'm not a dietitian, I tell them, really have to eat a Mediterranean type of diet. Being a vegetarian, it's a vegetarian paradox. In fact, the studies have shown, and I think in the Masala study also, 40% of the patients were vegetarians, which are large numbers. And we're vegetarians for religious reasons, whereas the Western population is vegetarian for health reasons. So I tell them, be a vegetarian for health reasons. Don't eat Indian food, rice and all that, and chapati, because you will eat more carbs to overcome the lack of protein. And that will make your risk even higher in terms of having cardiovascular problems. And studies have shown that there is a vegetarian paradox. You try not to insult anybody because it is religious, but I tell them, Mediterranean is essentially a vegetarian. And if you're a meat eater, there's meat in a Mediterranean type of diet. So instead of using rice, use quinoa. And once a week, you can cheat, but if you eat it every day, even unless you work out 4 to 6 hours a day, it's just going to be a problem. This problem will continue to be a plate. And I tell them, if you're 40s, your kids are in the 10, 15 years old, If they see what you eat and how you exercise, they will pick up those habits. And we don't know. The Masala study has a second arm to a third arm to it. Look at second generation South Asians. What is their risk for cardiovascular disease? So diet, I think, is very, very, very important. And adjusting it is also very crucial for long-term survival for these patients.
Well, Santosh, thanks so much. We have just a few minutes left. So it sounds like, if I could summarize what you've been telling us, the best way we're going to attack this kind of explosion in the incidence of vascular disease in this group is a combination of maybe earlier detection, more aggressive detection of risk factors, and perhaps more aggressive therapy of risk factors to tighter targets. And then perhaps a role for screening with calcium scoring and other modalities to detect disease at an earlier stage. Is that a fair summary so far?
Absolutely. That's perfect.
And of course, tremendous lifestyle changes, like you mentioned, to exercise, diet, weight loss, etc. I thought we would wrap up just by asking you what you think some of the future directions are going to be. I've followed this literature for 20 years, just like you have. And as you said, there's a real paucity of well-done studies that really are helping to guide us in terms of understanding this better and managing our patients. It's nice to see the Masala study, which of course is ongoing and is going to yield some good information. But what do you think are some of the unanswered questions that hopefully we'll get some answers on as we expand the base in the next, 5 or 10 years?
I think what we need, what is lacking is interventional studies. So we don't even know what statins do or PCSK9. What about fish oil? Vascepa, those kind of things. So, randomized trial among South Asians. I mean, we're almost at 5 million South Asians in this country. And it's amazing that there's not been a randomized trial for South Asia. Now, yes, Masala is going to have about 2,500 patients in their database, and they're looking at interventions, including called Saheli, which is where the daughter and the mother exercise together, diet together to see if it reduces cardiovascular risk. So there's many studies to come, but but there has to be randomized clinical trials. I mean, and so many South Asians are cardiologists. We should all get together and put these things together. So with the leading institutions such as Cleveland Clinic and all that. But without randomized trials, we're just extrapolating all the information. By a lot of it is just, experience from other South Asian centers. And it's what we go by a lot of times.
Well, we definitely look forward to learning more about your ongoing experience with your clinic and hopefully a chance to collaborate a bit on this growing population that we all are encountering. I just want to thank you again for taking some time to chat with Ben and I about this problem and give us some real practical management tips. Thanks again.
Absolutely. It's been a pleasure. Nice work, guys. Thank you so much.
Thank you for joining today's podcast. For more information about the speakers or the topics, please go to ohioacc.org.